When most clinicians evaluate a scan, they expect to see something exactly like this. That clarity comes from transmission imaging. A CT scanner fires a tightly controlled external beam of X-rays through the body, plotting the physical density of the structures inside. But when we shift from mapping anatomy to mapping physiology, the picture changes entirely. Radionuclide imaging is inherently noisy. Instead of using a predictable external beam, we are trying to capture multi-directional gamma photons emitted from radioactive decay happening deep inside the patient's own tissue. Capturing that internal decay has been a strict physical challenge since the earliest days of the gamma camera. The visual quality of every nuclear medicine image is governed by exactly 3 physical variables. These are the core pillars of image quality. First is contrast, the signal difference between a lesion and healthy tissue. Second is noise, the random variation obscuring detail. And third is spatial resolution, the detector's ability to distinguish 2 separate points of radioactivity. Optimizing a radionuclide image is a mathematical zero-sum game. The physical laws of the universe dictate that improving one of these 3 pillars almost inherently degrades another. We must distinguish between what is happening in the body and what appears on the monitor. Subject contrast is the biological reality, the actual ratio of radioactivity taken up by a lesion compared to healthy tissue. In a perfect scenario, a hot lesion has a sharp boundary and high relative activity. That biological reality is defined by this equation, measuring the activity per unit volume of the lesion against the surrounding cells. But that exact contrast degrades the moment those emitted gamma photons attempt to exit the body. Deep photons are stopped entirely by tissue attenuation, while others scatter off their original path before reaching the detector. Further complicating the signal, background gamma radiation for overlying and underlying tissues creates a fog over the cross-section. By the time the signal hits the camera, we are left with image contrast. The count density per pixel drops dramatically compared to biological activity. Because of attenuation, scatter, and background radiation, the image contrast displayed on the monitor is a direct physical degradation of the true subject contrast. Once the signal reaches the camera, we encounter the second constraint, noise. We can ignore structured noise, which comes from unwanted physiological uptake, and focus on the primary obstacle, random noise or quantum model. Radioactive decay is a random process. The image is built from unpredictable, sporadic emissions governed by Poisson statistics. Noise follows a strict mathematical rule. Random noise equals the square root of total counts. Our overall signal-to-noise ratio is total counts divided by that square root. We derive the final relative noise contrast as 1 over the square root of area times count density. That square root creates a punishing limitation in clinical practice. If you want to cut the visual noise in your scan by half, you cannot just double the signal. You have to quadruple the total counts. Quadrupling the counts translates directly to the patient's physical reality. It requires either leaving them in the scanner for an impossibly long time or injecting a massive dose of the radiopharmaceutical that reaches absolute safety limits. The laws of physics prevent the technologist from simply turning up the exposure to eliminate random noise. Instead, we must accept a noisy baseline.
The final pillar, spatial resolution, determines our physical ability to distinguish 2 separate points of radioactivity. This chart plots a line source function. When we image a single radioactive line, the system spreads that signal out into a bell curve. We quantify resolution by measuring the full width at half maximum, the exact horizontal spread halfway up that curve. The detector's electronics create the initial limitation. The physical thickness of the scintillation crystal inherently scatters the light signal, widening that curve to create the intrinsic resolution. But the largest bottleneck in planar imaging is the thick grid of lead sitting between the patient and the crystal, the collimator. Collimator resolution is governed by this equation. The most volatile variable here is B, the distance from the radiation source to the collimator. The further the patient is from the detector, the more the gamma rays diverge. This geometrically widens the curve and blurs the image. Variables H, hole lengths, and D dictate diameter. To engineer sharp spatial resolution, you need long holes and narrow diameters.
But as holes lengthen and narrow, the vast majority of photons strike the lead and are absorbed. The sharp resolution starves the detector. The collimator enforces an inescapable physical compromise. You can have sharp spatial resolution, or you can have low noise. The lead prevents you from having both. Positron emission tomography bypasses the collimator bottleneck entirely. Instead of capturing single gamma emissions, PET relies on an annihilation event. A positron collides with an electron, sending two photons flying in opposite directions. Detectors form a ring around the patient and use electronic coincidence. When two sensors register a hit simultaneously, they draw a direct line of response. The system no longer requires physical lead septa to reject scatter. Stripping away the physical lead massively increases the geometric detection efficiency of the system, solving the severe noise constraint of planar imaging. Yet, while PET avoids the collimator limits, it encounters strict quantum boundaries. The first boundary is positron range. A positron travels a winding path through tissue before annihilating, about 2 millimeters for oxygen-15. Second is non-collinearity. If particles retain residual momentum at annihilation, the resulting photons deviate slightly from a perfect 180-degree line. PET rewrites the rules of noise and sensitivity, but positron range and non-collinearity place an absolute, immovable boundary on the maximum spatial resolution the system can achieve. These physical constraints are not isolated variables. They operate as a single, highly sensitive system. This diagram illustrates the direct tension between contrast, noise, and resolution. If you adjust the collimator hole diameter to capture more counts, your noise metric improves immediately, but the spatial resolution drops significantly. When a nuclear medicine scan appears highly pixelated or noisy, it is rarely a software flaw. It is the exact mathematical output of these uncompromising equations. These exact physics dictate the physical actions in the room. A technologist relies on tight parameter controls, balancing scan time, injected ENS, and minimizing the physical distance to the patient to fight the geometric spread of gamma rays. Mastery of nuclear medicine physics isn't about achieving the crisp anatomical clarity of a CT scan. It is about calculating the precise mathematical compromise required to answer the patient's specific diagnostic question.